What's up, Des Moines? Doc Ladd here with the Fit Moines podcast. Today I have Dr. Eric Reynolds with Capital Orthopedics. Thank you so much, Dr. Reynolds, for being here.
Absolutely. Happy to be here.
Yeah, appreciate it. Let's get started here. Let's just have you explain a little bit about your background and where you come from and how you got into what you do now.
Sure. So I grew up in Coralville, Iowa, graduated from high school at Iowa City West High, did undergraduate and medical school at the University of Iowa. Decided that I needed to spread my wings a little bit from the tiny 5-mile radius that I had lived in for the first 26 years of my life, and did my medical training, the first part of my residency actually in pediatrics down at the University of New Mexico in Albuquerque. Stayed down there a little bit longer doing some additional teaching as a chief resident, and then went over to Cleveland, Ohio to do my sports medicine training. I worked there with Kent State University, the Cleveland Browns, a bunch of high schools and kind of small colleges in the Cleveland metro, and then moved to Des Moines about 6-7 years ago at this point in 2019. And I initially started at Mercy doing kind of half and half pediatric urgent care and sports medicine, and then really wanted to transition into sports medicine full time. And so joined Capital Orthopedics almost 3 years ago to the day here in March, and have been here since then.
Nice. Yeah. So we've both been in the metro since 2019 then. Interesting. Now, you did pediatrics and then sports medicine, so a little bit different from what a lot of people do, I guess.
Yeah.
Was pediatrics what you initially wanted to go into, or?
A good question. Actually, I knew I wanted to do sports medicine first, so
Okay.
it's a kind of a complicated thing to try to describe. So when you go to undergraduate, then you go to medical school, and after medical school, you go to residency. And so residency can range from 3 years, like family medicine, pediatrics, to 7 to 8 years, depending on what kind of neurosurgeon you want to be. And sometimes even up to 10 if you're really looking for really super specific types of things. Sports medicine is a fellowship, so it's something that you have to finish your residency training in some sort of what we call primary care specialty, which is pediatrics, family medicine, internal medicine, although that's pretty uncommon, emergency department or ER medicine, and the other one is what they call physiatry or physical medicine and rehabilitation, or PM&R. So those are kind of the 5 main kind of primary care routes into sports medicine. Then you have your more kind of what most people would refer to as traditional, which is orthopedic surgery residency, and then a sports medicine fellowship. Those are the surgeons. That's separate, and we'll talk about how we work together nicely, I'm sure, later in this conversation. But from me, I knew I wanted to do sports medicine. The bigger decision was, do I want to do family medicine to get there? Do I want to do pediatrics to get there? Do I want to do orthopedic surgery to get there? And I realized pretty quickly that I liked talking to people, which is why you'll probably get some pretty loquacious answers today. And so that really doesn't really work for being a surgeon when you're here, there, boom, boom, and you're spending half your time with patients who are unconscious on the operating table. So for me, I knew I wanted to be a primary care base, and I just liked working with kids a lot more than I did adults. That's really what it came down to. It was a pretty straightforward decision there. I didn't like adults who complained a lot. And so I was like, well, if I'm going to go through training, I'm just going to do pediatrics because I enjoyed that a little more. In hindsight, you could argue that family medicine would be a little bit more applicable, especially to what I do daily now. I see more adults. I enjoy seeing adults. I take care of adults, but back then I just, did my time in the neonatal intensive care unit serve me for how I'm practicing today? Probably not, but I found that path to be at the time, the most tolerable, knowing kind of what my end goal was.
Yeah, interesting. Are there sports medicine physicians that have not done that fellowship? I would assume that most places want to hire someone that's been through the fellowship and training, but is that a requirement, or?
If you want to call, in my opinion, if you want to call yourself a sports medicine physician, it's a requirement. Sure. That's why I call myself a primary care sports medicine physician. And then the usually obvious follow-up question is, what the heck is that? Because it's not something that you hear a whole lot about. If you're really calling yourself a physician of sports medicine, then you need to have completed that additional fellowship training, additional board certification, that kind of stuff. To my knowledge, there's only about probably 14 to 15 of us in the state of Iowa who are primary care sports medicine physicians. I think there's, off the top of my head, 5 to 6 of us here in Des Moines, and then the rest are over at the University of Iowa. So it's much more, much less common than going the orthopedic route. Now, there are plenty of family med docs who feel comfortable treating a variety of sports injuries, but to really kind of get that title as a sports medicine physician, or what in the kind of a medical parlance is CAQSM, where essentially we take an additional certification of sports medicine. Then you have to have completed the fellowship and taken the exam.
Sure. Yeah. And I guess we have a lot of people too, when I'm sending a patient over to you, they always ask, like, is he going to do the surgery? Who's going to do the surgery?
Yeah.
Said, no.
My typical response is, you don't want me doing surgery. I'm going to make you worse than what you are now. You let me in the operating room, and usually it's going to lead to a butchering situation. So yeah, I do not step foot in the OR. No, I do a fair amount of procedures, which again, I'm sure we'll talk about. I frequently have an ultrasound and a needle in my hand, but I'm not going in and sewing
Yeah,
anything back
not
together unless, I'm on a sideline and you happen to get a cut across your cheek, then I'll do that. But
sure,
that's about it.
sure. Yeah, well, this is a good segue. Why don't we talk a little bit about the patients that you do see, typical injuries that might come into your office, things like that. So,
Yeah, I'd say I see people ages 9 months to 95. I think that's my current record for youngest patients I've seen in clinic to oldest. I'd say the vast majority of patients I see I can qualify kind of into three buckets. One would be high schooler kind of overuse injuries. I see a fair amount of traumatic injuries, fractures, ACL tears, that kind of stuff. But in terms of people that make their way into my clinic, it's usually stress fractures, it's tendonitis, growth plate irritation in the pediatric population, people that have kind of overuse injuries in kind of the middle school, high school, and sometimes even elementary school realm. The next bucket I would say are your people kind of like myself who are, in their 20s, 30s, 40s and pretty active, and they also tend to get kind of overuse injuries. And then the last bucket is people in their 60s and 70s with arthritis pain. And so that'd be in terms of the injury standpoint in the patient population that I see, that's a good chunk of it. And then throw on top concussions, which is a whole other separate kind of podcast topic, but I see a fair number of concussions as well.
okay. Yeah. Tell us about, if a patient's coming in to see you, what can they expect from that visit? I mean, you talked about ultrasounds, injections, some other things. So just talk about a typical visit, what that looks like, and then some of the services you can provide. And then we can hop into imaging and referring to a surgeon as well, I guess.
Yeah. So the thing that I would say sets me apart from, well, a lot of doctors, but especially surgeons, is that new patients are going to see me for 30 minutes. So you're going to come in, we're going to have a legitimate conversation, not just point where it hurts, let me do an exam. All right, we'll get an MRI, see you later. Like it is like, all right, I'm going to get to know you. We're going to get to know the activities you enjoy, how this pain is interrupting your life. Is it causing you to not be able to play pickleball this week? Is it limiting you from doing deadlifts at the gym and you really like doing deadlifts? Is it interrupting your sleep? Really trying to get to the bare kind of foundation of how is the pain or the issue you're having impacting your day-to-day life, and essentially what is making it so you sought care at a physical therapist office, or you're coming in here on your own, or your primary care provider sent you here, whatever it may be. So really getting down to the nitty-gritty of what that, and so that could take time, obviously, and then we'll do a really detailed exam. We're going to go over everything, kind of, examine the joint in full. If I believe it is a bony problem or we're worried we might have to get additional imaging, we have x-ray on site, so we'll get x-ray. Or if we've had pain for a long period of time, we just want to rule out some other stuff that would be happening underneath the surface there, we'll get an x-ray. And then I do have an ultrasound in clinic. I have additional training in what we call diagnostic ultrasound and ultrasound guided injections. So let's say it's a, kind of a case of what people would call tennis elbow or lateral epicondylosis. I can, if I have clinical concern for a tear, or the therapist who's sending them to me, like, hey, they're pretty weak, like I wonder if they have a pretty sizable tear, I can put an ultrasound on there and pretty reliably diagnose kind of muscle injuries in that way. We can do the same with the rotator cuff. So sometimes can either save the need for an MRI and say, hey, like we don't need to spend that time and money doing that because we can find out here today, or can confirm that, hey, this is actually necessary. Like I'm seeing this, and this is an indication that we might need something further. For example, like in a knee pain, somebody might have what we call kind of a perimeniscal cyst. And so that can be a sign outwardly that they probably have a meniscus tear. I can really identify and characterize that under ultrasound, but I really won't be able to see the meniscus tear itself without an MRI. So that can be where like, yep, this is the findings we have. This supports the need for additional imaging. And then if people have had pain long enough, and depending on our conversation, if, they've done therapy for a while and they've kind of tried what we would kind of generally term conservative management, and an injection is a good therapeutic option for them, we'll do that at the first visit if we need to. So I just did a radial tunnel injection this morning. Like we can do a wide variety of injections, especially with the use of ultrasound. Like it really is a game changer in terms of accuracy of injections, patient pain. We can say, oh, well, here's a blood vessel or here's a nerve that we want to avoid while we do this injection. I can kind of kind of take a little slightly different path. We can ensure, again, that the medicine is going to the right spot. They've done plenty of studies in ultrasound, for example, in a knee injection increases the accuracy about from 80 to 80% ish, doing kind of landmark guided, up to 95 to 99% with ultrasound. It just is it's a much more guaranteed kind of bang for your buck. You're making sure that the therapy we're delivering is going to the right spot.
Yeah. And from past experience for me, while I was in the Navy, one of our clinics shared space with a sports medicine physician. And so I got to see firsthand just how valuable having that ultrasound right there in the clinic was. Like you said, what's this Achilles look like under this ultrasound, or the elbow? Like, what do we really got going on here? Do we need to get that MRI, or can we keep rehabbing it? And it's so handy to have right at the bedside there.
Yeah, especially from a PT standpoint, like you can see, like for an Achilles example, like you can see significant thickening, what we call neovascularity, where you get a bunch of blood vessels and you're like, whoa, this is, for lack of a better term, a really angry tendon.
Yeah.
We might have to pull back on what we're doing from a rehab standpoint. Like we might be overloading it at the first part and have to go back to a little bit more basic stuff. Same thing if we have like a gluteus medius tear, so like that kind of pain on the outside part of your hip, and you're like, they're just really not responding like I would expect, and they're still having pain with very basic stuff. We can say, hey, well, yeah, it looks like this is maybe a little bit more severe than we otherwise initially expected, and so you kind of have to take a couple steps back and from a therapy standpoint. But conversely, you can also take a look and say, hey, this actually looks really good. Like I think we can continue to load this, and maybe be a little bit more aggressive in our loading. And sometimes that's where negative imaging, even an MRI or an ultrasound, can be helpful and say, hey, this actually looks fine. Like we can have a little bit more license to push through some pain and some discomfort, which can be equally valuable for patients and therapists.
Yeah, for sure. Yep. I always tell people, like, the special tests, those tests we do in clinic here, they're only so good, right? We can cluster as many of them together as we want, but sometimes you need that imaging. And so be able to get an ultrasound and say, yeah, we need to get this MRI. Let's check it out a little bit further. It's very valuable.
Yeah, the shoulder's the classic examples. For the listeners, there's things called what we call sensitivity and specificity, which is pretty much just like how reliable is this exam maneuver, or this test, this blood test, whatever it may be, at kind of ruling out the stuff we want to rule out, or assessing that for positive things, the things we want to rule in. The shoulder exam is a textbook case. Like you're having nothing over above like 60 to 70%. And so that's why every single part of the shoulder has 3 different exam maneuvers, right? And that's why the shoulder exam it takes 5 times longer than an elbow exam, is because there's so much overlapping structures that you can't really isolate things. Well, on ultrasound, you can isolate things. You can find it and like, here's the tendon. And the best part ultrasound has above a MRI, for example, MRI is a static exam. You are stuck in that darn tube and you are multiple times told not to move. With ultrasound, we're going to like, hey, you've got a weird pop in that shoulder. I'm going to put my probe on here on the shoulder and let's recreate that pop and see if we can identify what the popping has come from. Found a case just a couple weeks ago where somebody essentially had a little extra kind of tissue over their subacromial bursa, and you could see it as they kind of brought their shoulder internal rotation and kind of into flexion. You could get that to pop kind of out from underneath the acromion. Now, could I necessarily do anything to fix that at the time of our appointment? No, but at least we could finally figure out like, hey, this is what it is. It's actually probably not a big deal long term, as like not really having any pain. It was more of a painless kind of curiosity for this patient. And so that's where the dynamic modality especially can be helpful. Back to our tennis elbow or kind of lateral epicondylosis example, like I can have them flex and extend their wrist with the ultrasound probe on there to see like, how is this tendon fluidly moving? Tendons, how they look in a static position is not nearly as important as how they function dynamically, right?
Right.
Like,
Yep.
and so having that capability during an ultrasound to see like, all right, this is how it looks with your knee flexed. How does it look with it extended? Does it look different? Do we have any sort of overlap or kind of tendon, kind of irregularities that maybe more demonstrate themselves at a particular kind of plane of motion? So just as, again, can give us a lot more information.
Yep. We always tell people that as well. The MRI, it's super valuable, but that's a static image at one point in time in your life. For a herniated disc or something in your back, that changes over time, or it can.
Yeah,
and so
we hope it does usually.
Right. Yeah, we hope that resorbs, it comes back, it resolves, your pain goes down, but it's a picture in time, and that's kind of all it tells us. So like you said, that's super valuable to have the ability just to move that joint around and see what's really going on there.
Yeah, and again, it's it just adds a different element that X-ray and MRI don't have, right? And so you can use
Yep.
it to kind of support that. Like, oh, there's a little bit of swelling around this bone. That's unusual. That even though the X-ray looks fine, like this might be a stress fracture or stress injury, and just because of what you can kind of pick up on ultrasound.
Yeah.
And again, from an injection standpoint, again, I can't tell you the last time I did an injection with that one, just because it increases our chances of hitting the target.
Yeah. Let's talk about the injections a little bit because I think that comes up a lot here. Sometimes, at least in our world, they kind of get a bad rap. Is this just throwing a band-aid on it? Is this going to solve the problem? Those are questions people ask us all the time. And so I've got my answer, but I want to hear yours.
Yeah, as with all things, the easy answer is it depends.
Right.
There are sometimes it's a flat out Band-Aid. That's not incorrect. I would say kind of a classic example of that might be like a steroid injection in an arthritic knee. Like you're not fixing anything. There's a chance you might be making something worse, but it is probably going to make your pain better. And so that's why again I have these 30-minute appointments, because that has a lot of nuance to it. Okay,
Yep.
if you're a 52-year-old with knee arthritis and I do a steroid injection and I'm going to accelerate cartilage loss in your knee, that's probably not a good thing. You have hopefully a relatively long life to live still. Knee replacements have a shelf life, 15, 20, 25 years. And if you're 52 and otherwise healthy, and let's say you just had two ACL tears while you were in college, and that's why you have arthritis at 52, like that's a very different conversation than somebody who's 72, otherwise healthy, and just kind of has some arthritis due to maybe a little bit of poor metabolic health, or a lot of it's genetics. Arthritis, again, is a whole separate conversation in itself. But in that
Yep.
person, we're going to have, I wouldn't have nearly as much trepidation about doing a steroid injection, with the understanding that, hey, you might be working towards a knee replacement. And like, yeah, it's a Band-Aid, but it's going to give you an extra couple years of life here. Or you got a trip to
Yep.
Florida coming up and you want to have a little less pain as you're walking on the beach. Like, hey, by all means, I get it. Let's do it. So that's where that type of thing can be helpful for things like, rotator cuff tendinopathy, or what people refer to as like shoulder impingement. Like there, and a lot of other conditions like that, I kind of view an injection as an adjunct to physical therapy. Like there's really only one condition that I can think of where like an injection should be first line and is really all you need without therapy. And that's de Quervain's tenosynovitis, or kind of the new condition moms get with like newborn babies in the kind of thumb side of their wrist. To that, we know that therapy, studies show it's not super helpful. Injections usually are pretty effective. That's all you need. Otherwise, like people like, oh, I'm not a PT person, I just need an injection in my shoulder. Like studies time and time and time again will tell you that therapy is the answer for long-term pain relief. Injections are going to give you 4, 8, 12 weeks, depending on who you are. If you're lucky, sometimes longer, but it's not going to fix the underlying problem. It's just going to make your pain better. So how I describe it to patients is, hey, we're going to make your pain lower. We're going to make it so you can sleep, but that way you can attack your rehab with a little bit more vigor, with a little bit more gusto, and really work on the strengthening component of the muscles that they need to get better. Because I'm sure you guys have seen, like, you're trying to do super basic band exercises and they're just limited and it's
Right.
uncomfortable and painful. And you're just
Yep.
like, man, I can't really do much if you physically as a patient
Yep.
can't do much.
Yep.
And that's where an injection's helpful. That I consider just kind of a push in the right direction, but it's not just a put, an injection. They're like, all right, you don't need to go back and see Brian. You're good. See you later. Like
Yeah.
it's all right. Now you'll be able to do more at therapy. You're going to accomplish more, and that's going to be our more long-term solution.
Right. Yep. That's kind of how we explain it as well. It just kind of creates that window of opportunity to where you actually feel good. Like you said, you can get some sleep, you can rest up, your body can heal itself, but also your pain has gone down. So we can actually go out to the gym and get into some of the work that we actually need to do to help progress this. And so sometimes without that injection, and like you said, it's just can't hardly get anything done because it's so painful. And so,
And the sleep is a huge component. You've got quite a few kids. I've got quite a few kids. Like we know what life is like without sleep or with little sleep.
right.
There's really good studies. I think one just came out, honestly, in the last couple weeks, that showed that if you're really getting less than 6 hours of sleep, like, I don't want to say exercise is pointless, but you're really not getting a whole lot of benefit with it, because that's when you recover, right? Like exercise is
Yep.
anything you're doing from a running standpoint, a lifting standpoint. Like what you're trying to do is introduce microscopic tissue injury. And then your body goes, crap. Well, I need to heal this stronger so that that particular load or amount of exercise doesn't cause that injury again. And
Yep.
then that healing happens mostly with appropriate nutrition and also with sleep. And so if your pain is bad enough that it's interrupting your quality of sleep, your ability to heal and respond to even the therapy that you're doing or the home exercises that you're doing is just so much less. And so if you're not sleeping well, your chances of getting better with rehab is just, it's just not as high as people who are getting a good night's sleep, and pain
Yep.
is a big part of that.
Yep. Yep. And it's not just the athletes either. I had a patient just yesterday. She's kind of been through the ringer, 3 different total hips on the same hip.
Oof.
Yeah, it's a mess. But one of the things we got to talking about during our session yesterday was sleep, first off, but then she's worried about being too sore. So it's like, okay, well, what's your protein intake? Let's talk about that. Let's get some quality protein in there. And we talked about creatine. How can that be helpful with her
Oh,
recovery as well? So kind of all the hydration, we talked hydration and electrolytes, things like that, but all those kind of mixed together along with the exercise to help strengthen her up and get her moving. So there's a lot that goes into it. And she's, like I said, she's not an athlete.
yeah, it's very often that I'm seeing patients kind of in isolation and like I'm the only person kind of responsible for their care, right? My wife, who's also a physician, just jokes that 90% of the time all I do is prescribe physical therapy and ibuprofen. And she's not wrong probably. Again, there's very few conditions in my world and overuse injuries, even acute injuries that are going to, get better by doing nothing. And so,
Yeah.
you know, a physical therapist, having good communication with your physical therapist is important. I'm sure you can attest to that. Like, I have plenty of patients that come in and thankfully over the years of working here, I've just been able to build a good, essentially network of phone numbers of a lot of the common therapists that my patients will
Mhm.
see. And so it's just much easier to be like, hey, this is what I'm seeing on exam. This is what I'm seeing on everything. This is my plan of action. Here's what I would kind of clue in on therapy and go that direction, right? And
Yeah.
then for your nutrition point, like, hey, like you're a serious athlete, like this is your second stress injury, like we got to take a look at this nutrition stuff. Like, here's the
Right.
name of a sports nutritionist I like to use. Or sometimes it's athletes coming back from a bad injury and they just can't quite get over the hump mentally. And like, hey, here's a few sports psychologists in town. Why don't you use them? Like,
Right.
it really is a team effort.
Yeah.
And so at least for people that really want to kind of put the full court press on their healing potential or their
Yep.
rehab potential, like we can definitely bring in a lot of people into the circle to help. Now, sometimes it's just me and a physical therapist, and that's all we need. But for some of those patients that are a little more stuck, have a little bit more serious pathology or a little higher level athlete, then a lot of times you're going to have quite a few chefs in the kitchen, and that's okay as long as those chefs know how
Right.
to communicate and work together.
Yep. Yep. That communication piece is huge. And I tell people too, when they're in here and we're looking at them, it's like, yeah, I think you need some imaging. The state of Iowa recently changed where physical therapists can order imaging. We can order x-rays, MRIs. And that's something I did when I was in the Navy. I have no problem doing that. But I always tell people or oftentimes tell people that it's good to loop in, especially a physician, especially if they don't have a primary care, but just to get another set of eyes on things. And then you can order the imaging if you deem that's appropriate. I think it's just helpful to get someone else in the loop. You've got a different skill set than I have. And so it just to be able to manage the case a little bit better, I think it's so helpful to have a sports medicine physician on board to help out with all that.
No, for sure it is. That change patch recently. I think it's helpful for especially in smaller towns where you may not have access, and it's just kind of, hey, there's 3 primary care docs. It takes a month to get in, and I have open access, which is a great thing for physical therapists here in the
Right.
state of Iowa. And I can just go see a PT without a physician giving a prescription. Like, there might be things you want imaging from quickly, and that's better. Here in a large metro area like Des Moines, I would say that the indications for a therapist ordering imaging, I would say, are a lot less, just because again we have so many available resources around.
Yep.
How I phrase it to patients is I pride myself on being a good diagnostician. I am going to find the problem, find the source of your pain. We're gonna go a history, like, oh, you had an acute injury, like, let me see the video of it. Why don't you pull up your high school tape? Let's break this
Yeah.
down. Like, do that. We're gonna do a detailed exam. We're gonna get X-ray, MRI, ultrasound, whatever, because as a therapist, you guys are the ones treating them. Like, I tell people all the time, like, I'm very rarely going to really do it. I'm not going to lay my hands on you and magically you're going to get better. Like, it's really physical therapy. You guys are the people who do the treatment, but it's a lot easier to come up with a treatment plan when you have an accurate diagnosis and you know kind of what to hone in on. Like, okay, it's this particular muscle. I'm going to kind of ignore the rest of it and we're going to go there. Or like
Yeah.
people who have hip and back pain are famous for kind of crossing over, and it's like, all right, what's our pain generator here? I have pain in my butt and then it kind of maybe comes around to my groin and I have pain shooting down my leg. Like, that can be back pain, that can be hip pain, that can be nerve pain. Like, there's a bunch of different
Yeah.
options. And so really getting to see somebody who can whittle through and step by step kind of have a systematic approach to really finding the true pain generator to then help you do rehab. Because sure, you guys as therapists are going to have crossover on back and hip pain, but hip bridges and clamshells are going to be a heck of a lot more useful for hip pathology than they are discogenic pathology. And
Right.
so it's there, like doing a diagnostic injection. Like sometimes we just need to put a little numbing medicine into a spot and see if it helps. Right. And that's
Yep.
sometimes that's what it comes down to.
Yep.
And thankfully with ultrasound we can do that. Like, hey, I got a pain kind of in my glute muscle here, and like, okay, like let's go under ultrasound. You point where it bothers you, I'll place a little skin marker there. We'll go under ultrasound. We'll place a little bit of lidocaine there. We'll have you jump around in clinic or go walk up and down the steps, and if your pain's gone, like, okay, we found the issue.
Yep. Yep.
And so it's those types of diagnostic cases are some of my favorites. Just because the interplay between our professions is so much better there. Like, hey, I'm worried about this. Like, all right, you're coming, we do an evaluation. Like, okay, I start to have really bad hip pain when I'm doing my 8th rep of a deadlift at the gym. And it's like, all right, well, you're going to come back next Monday morning because you're off on Mondays. I'm going to do an injection. You're going to go from my clinic straight to the gym, and we're gonna do it that way.
Yeah.
And again, that's so much nicer than you guys getting X-rays and being like, the radiology report says this, and it's. I disagree with radiologists occasionally, not often. I would say I'm nicer to them than my surgical colleagues, but we have a huge advantage for us in that I can see the patient, I can examine the patient. And so, I have patients that are like, oh, well, the radiology, the finding, the MRI says this. And it's like, well, it's not at all really where your pain is located. So I
Yeah.
think that's a red herring. And so some of that imaging is, I don't want to say worthless, but it doesn't give us the answers we're looking for. And not to get too long-winded, but there's, again, a recent study that came out in the Journal of American Medical Association that essentially had incidental rotator cuff findings. I'm sure you saw this the last couple of months. And pretty much once you hit like 51 to 55 years old, it's almost 100% guaranteed you're going to have an abnormality on your shoulder MRI. And so at that point, like, what use does getting an MRI really do if it's going to show something wrong? Like, that's where, again, we put our history together. What movement patterns tend to bother you the most? That's where diagnostic injections are going to be more helpful rather than seeing a gung-ho surgeon who sees a partial thickness rotator cuff tear and is going to want to go in and repair it.
Right.
That might be end up what you need, but I can tell you over 50% of people your age have partial thickness rotator cuff tears, and a lot of them don't have pain. So, let's really try to figure out what that pain generator is. And
Yep.
so that's where interpreting that imaging is where I think I don't want to, stand on a pedestal and say, oh, we're better than therapists, but like that's where our interpretation and knowledge and things can really help to kind of get through the weeds of some of those
Oh, for
imaging
sure.
questions.
Yeah, no, I agree completely with that. And I kind of laughed at that too, because my time in the Navy, I spent a lot of time over in the orthopedics office and just listening to them talk and going through cases and whatnot. And I can't tell you how many times that the radiologist would say one thing and the surgeons would sit there and say, no, that doesn't matter. Look at this here. And so just kind of funny. Like,
Yeah, they're friendly. I have all their phone numbers. I can call them, but it's usually just like, hey, this is what I'm seeing in clinic. And the issue is, thanks to a lot of our medical record system, and here in Des Moines, it's pretty unique, and I won't share too many frustrations, but it's a decentralized medical system, right? Like, you have
for sure.
kind of 3 main medical groups, and one group has this specialty, another group has this. So just the communication between large medical groups or even small kind of private practices like mine, like, it's hard. And so like you'll tell your medical assistant, like, I'm worried about a tear in this muscle. And then like you see the indication that the radiologist sees when they're reviewing the study, and it says shoulder pain. And okay, well, we're not giving the radiologist the helpful information of like the very specific finding I'm looking for.
Yeah,
And so that's when I'll pick up the phone and be like, hey, this is why I got this. Like, let's walk through this together
sure.
and see if we can come up with a better kind of interpretation of what's in front of us.
Yeah. Yeah. To touch on one of your points as well, one of my favorite things about working with Capital Orthopedics is the communication piece. If I send a person up to you, most of the time you're texting me to tell me about the patient before I get the notes anyways, but usually it's not long after we've talked or we've touched base that the notes are already faxed over. We have everything. There's been so many times where, a patient will walk in, they're like, hey, Dr. Reynolds said this. And I'm like, I know, like I have everything already. Like, yep, that's great. But the communication is so nice because it's like, it's just immediate. And I can tell you, it's not like that everywhere.
Yeah, I mean, I'd say that's one thing I really pride myself on, and I'd violate HIPAA if I showed it up. But like every single patient I see, like I'll write usually the athletic trainer or the physical therapist, just kind of in the top left corner. So like before I'm done with that note, that encounter, like I know, like, I got to text Brian about this, or like, because it might be between patients, I'm not going to have time to fire off a 2-minute voice message or whatever it may be based on detailed ultrasound findings. But I just know by the end of the day, like, hey, before this patient goes and sees Brian for follow-up in 2 days, like I need to make sure he knows what I saw here. Again, just because it makes your job a whole lot easier, right? Especially
Absolutely.
like to go back to the injection stuff. When we're talking plus or minuses of injections, like there's a lot of times I'll be like, hey, let's hold off for now. We have a little bit more information than what you came into the office with as to what we think the problem is. Let's go back to therapy. Let's give it another 4 weeks, like where we now have a little bit more of a detailed, kind of honed in plan. Then you come back and see me after, again, more specialized rehab for a particular muscle or a particular motion, whatever it may be. And then if we're not making the progress, then we know we're going to get an injection, as opposed
Mhm.
to, I'm not going to name names, but some other office, and it's just like, no, you're fine, go back to therapy. Like, okay, sure, I'll just continue beating my head into the wall for the next 4 weeks. That sounds great. And I think a lot of that, the emphasis for me on that part is really twofold. One, it helps the patients, right? Like they know that
Yep.
their care team is communicating and not completely different silos, and so they feel more taken care of, and it increases the quality of care, no doubt. And the other is my wife's a primary care doc, and I know how frustrated she can get when that happens to her. They'll send somebody to an orthopedic surgeon, and they'll be like, "Nope, not a surgical problem," and that's essentially all the feedback she gets. And she's like, "Well,
Yeah.
I still need help with this. Like they're not doing
Yeah.
well, and this is kind of out of my area of expertise. I don't even know where to send them now." And so
Right.
that kind of communication can be helpful in terms of doing that. And that's one thing I pride myself on, is just making sure people are in the loop. And if I can't help you, I've usually been in this long enough and kind of know enough people that I can at least point you to the direction that somebody who can.
Sure. Yeah. Having that network is super valuable as well. I want to talk about one other thing that we've kind of talked about a little bit already, but just access to care. And, you mentioned rural areas, and we don't have to worry about that here in the metro, which is kind of nice. But one of the other things that I really like about Capital is how quickly I can get a patient in to see you. So I know there's different orthopedic urgent cares in the area, but you guys take walk-ins. I know you have scheduled appointments as well, but I know I can get someone in really quick to see you. And I think patients just love that ability as well, to be able to get into the physician and don't have to wait weeks to do it.
Yeah, it's actually a main point of kind of pride. Something we really emphasize is just accessibility. One of my colleagues, Dr. Peterson, always likes to talk about the 3 A's in terms of physician-patient relationships. It's ability. So essentially, are you a good doctor? Affability. Are you a nice person? And then
Yeah.
accessibility. And so we really try to prioritize all three. And for me, like, again, like I know a lot of people who come into my clinic usually are frustrated in some way, shape, and form. They're not getting better with physical therapy. Maybe they have an acute injury. There's a lot of uncertainty about their pain. And is it something you can work through? Is it something you can't? And I try to remember that.
Yeah.
And so just saying like, yep, that's all right. Bring them on in. Like, especially if it's a walk in and we're already busy, I might be like, hey, you're going to have to wait, 30, 40 minutes. Like, I'm sorry, but I would be happy to see you. I want to see you. I want to take care of you. And if they're like, I don't have that time to wait, it's like, okay, here, there's an 8:30 tomorrow morning. How does that work for you?
Sure.
And so we really just do our best to make sure that there's easy access. And again, what separates us from, I would say most other orthopedic groups is just that when you're going to the walk-in with us, you're seeing a physician. Like it's either myself or Dr. Wynn over in our office in Clive, as I'm up in our Ankeny office. The other urgent cares, whether that be orthopedic or just your regular kind of medical urgent cares. Like a lot of times you're seeing a PA or an MP, and they absolutely have a role in the medical system for
For
sure. But I
sure.
would
Yep.
say being like stupendous diagnosticians where they can take this huge block of information and try to whittle it down is to get an accurate diagnosis and treatment plan. Like that's why we go to longer training. That's really what it comes down to. Is I would expect me to do a better job at that than somebody who went to school for 25% of the time that I did. Are they helpful in ORs? Absolutely. The PAs in our office are great in terms of doing injections and post-op visits and that kind of stuff. But when you have somebody who comes in is like, I've had shoulder pain for 5 years. I've seen 3 people. Like, no offense to the PAs, that's probably not their bread and butter as to what they're going to do. And so that's why access to physicians with us is same day, and that's pretty unheard of, regardless of specialty. And the best part about us is that we're small, we're mobile. We have 10 physicians. I know all of them. I can call all of them if I have a question. We have an MRI in our office in Clive. Other orthopedic groups have 40 to 50 physicians. They have one MRI. We have 10 physicians. We have one MRI. Do the math there. We're going to get you into additional imaging a lot faster. And then again, with Dr. Wynn and myself, we have ultrasound capabilities. Again, we're the only ones that will have point of care ultrasound. Nowhere else in the metro will you be able to walk in and get an ultrasound in the same day as your regular visit. And so that it is a point of pride for sure. And especially now in 2026, and people are like, I got 3 kids, I got soccer practice to get to tonight, I got this tomorrow. Like they don't have time, and today's the day where they have 2 hours. Like, and we'll make it happen.
Yeah, and we've had it before too. Usually it's like Friday at like 5:30 or something. We'll get a patient come in, and it's inevitably something that needs higher level of care, and we've got to send them somewhere. So we've had to send people to other urgent care type orthopedic groups, and it's hard because I don't know what they're getting. I don't know who they're going to see. It's like luck of the draw who you're going to see. Do I send these notes over? Are you going to get it? I don't know.
Are you going to
And
read
so,
them?
are you going to read them? Am I going to get any feedback back? Probably not. So, it does make it challenging. So,
and it is, there are some patients that I'm like, I really wish you had called ahead. They've had 5 surgeries, and you're just like, I am not going to have time to review all that documentation before I see you today. Like that's, unfortunately, it's disrespectful to the people that are waiting after you, but like I can try to address what we have going on. But for you, it might be better off. Let's get all your records. Let's have you come back in a week and we can go from there. Whereas if people are just like, yeah, it's a pretty basic shoulder pain, whatever it may be, like that's where I really like, have relationships with you guys where I can be like, hey, that was a perfect walk-in patient. Or like they'll give me a story and they'll be like, is this somebody you want somebody to come up and see you now? Or is this something that you want them to call ahead? And I can kind of triage again based on the history, the amount of records we're going to need. Like, that I'd like to review all that stuff first. Our visit's going to be a little bit more worthwhile to the patient at that point if we're able to schedule that a couple of days down the line and I'm able to review everything.
Yeah, absolutely. So let's walk this down a little bit more. A patient comes in, they've seen you, you've done your exam. Maybe we've done an ultrasound, we've gotten the MRI. What happens after that MRI? Maybe there's a rotator cuff tear. Where do they go from there?
We're going to have a very detailed conversation. We're going to say, hey, like this is the size of the tear. This is what studies show in terms of, progression and what injections would be helpful. Rotator cuffs are particularly challenging just because what one tear might be painful for somebody is completely asymptomatic for another. A lot of that's going to be based on essentially how much PT have they done? Do I know the therapist? They've been at this for 2 months, 3 months, and like they have done everything appropriate and they are still uncomfortable. We've maybe tried an injection and it had, 3-4 weeks of relief, and you're still like, okay, all right. Like, then you're getting into orthobiologics, platelet-rich plasma. Like we'll talk about the pros and cons of that. And then a lot of times it's just like, hey, it's worthwhile having a conversation with the surgeon. Like I send enough people for rotator cuff repairs, I can tell you kind of the benchmarks of, okay, you're going to be in a sling for 6 weeks, and then you're going to get in this passive motion machine, et cetera, et cetera. But sometimes it's just nice to hear from the surgeon. And I always tell people, like, surgeons don't wave a magical wand. They're not going to convince you to get surgery just because you walk into their office. Like, view it as an educational visit. Just go understand what their repair would look like, what your recovery time would look like, how that's going to impact any upcoming trips or family time or whatever it may be. And then you have all the pieces of the puzzle in front of you, and then you can make the most educated decision. I think a lot of times in medicine, we struggle with either getting an accurate diagnosis or really kind of telling the patient what to do. Very rarely am I telling a patient what to do. I kind of always chuckle and feel slightly uncomfortable when they're like, well, what would you do in my shoes? And I'm like, like everybody's pain thresholds are different. Everybody's lifestyle is different. Like if I couldn't use my non-dominant arm, like for some people, it's not a big deal. Like I got 2 kids that I still are pretty young that I got to pick up pretty regularly. And if I want to do anything with my dominant arm, I better be using that one to carry them. That would be a big deal for me, right? So it's a very individualized discussion there. And then that's where my relationship with our surgical colleagues is helpful, because I can just shoot them a quick message and be like, hey, this patient is not set on surgery. Like, don't come in and be like, all right, okay, looks like you're getting surgery for that rotator cuff tear. Like, we can be a little bit more nuanced and say, hey, they're going to see you. They just want to hear about it. Tell them what the typical process is. And then if they decide to get surgery, great, they're in good hands. And if they decide, this isn't for me, maybe I want to talk about that PRP or shockwave or something else, then they'll come back to me and we'll have a further discussion. But it is very nuanced, and I wish I could give some sort of kind of carte blanche advice, but everybody's different. Everybody's pain is different. Everybody's kind of life goals are different. If you're 65 and you're just looking to, watch some television and go for a 2-mile walk every day and kind of be involved in your church, that's different than a 65-year-old who takes care of their grandkids, 4 days a week and has a golf trip planned to Scotland and whatever else. And so It is a very different discussion based on what our fitness goals are and what our quality of life is.
Yeah. I'm glad you brought it up too, because I wanted to ask, do you do PRP and some of those orthobiologics
I do.
in-house
I
there?
do PRP or platelet-rich plasma.
Yep.
For the uninitiated, we take usually somewhere between 60 and 120 cc's of blood. I'm just kind of like what we call a venipuncture. So just like you getting a lab draw at your primary care doc's office. For reference, a donation of a unit of blood is 300 cc's. So we're not vampires. We're not taking blood to the point that you're not going to be able to, go for a run tomorrow, whatever it is. But we do that. We spin down the blood to then essentially concentrate the platelets. So we get rid of a lot of the red blood cells, a lot of the white blood cells, and we focus on the platelets. Platelets are rich in cytokines, what we call inflammatory growth factors, and then inject that into usually the main two things I do it for are arthritis and kind of tendinopathy or small rotator cuff tears, small, kind of tears in your common extensor tendon for kind of tennis elbow type of stuff. So those are the main indications. The analogy I like to use with patients for that is it's like taking fertilizer and weed killer and throwing it on a field. Here in Iowa, good soil, right? Throw it on a good field. You're going to get the right things to grow. It's going to create a good environment for the right muscle cells, the right cartilage cells, whatever that we need to grow. If I take a fertilizer and weed killer and throw it on a rocky beach in Massachusetts, like I'm wasting my fertilizer and weed killer. And so you can have arthritis that's so bad that PRP is a waste of your money. You can have a tendon tear that's so bad that PRP is a waste of your money. And having the nuance there, I really pride myself on staying up to date on the data on this so that patients can have the most, again, educated opinion. I'm not going to tell them what to do. My goal is to just make them smarter and give them kind of all the information I can for them to make their own decision.
Sure.
So for us, and if you want, Brian, you can tell me, but like if I can go into detail on kind of what we're looking for in PRP, and for patients it helps and doesn't help, but that's kind of the general gist.
Yeah. No, that's very helpful, I think. So awesome. Well, Dr. Reynolds, I know you need to get going here shortly. Is there anything that we haven't talked about that you would like to talk about or you want people to know?
Yeah, I think one of the common questions is like, well, how do I know to come back to you? Or again, how do I know when it's time to see a doctor, right? Or when do I need to see a sports medicine doctor?
Yeah. Or
I
do
would
I need a
say,
referral?
yeah, good question. The answer to that is no. To see me, you do not need a referral, with very rare one insurance exception. But yeah, so you don't need a referral. What I tell people is, if it is lessening your quality of sleep and keeping you from doing the activities you want to do, then I should be seeing you. If it's like it's 1 out of 10 pain, I can kind of work through it, not a big deal, then you're handling it well. You probably don't need to see me. But if it's keeping you from the things you enjoy, if it's ruining your quality of sleep, if it's going to take you 2 to 3 weeks to get into your primary care doc, again, primary care physicians are so overwhelmed and overburdened in medicine these days. They have so much to worry about. You're going in there, all right, we need to check up on your blood pressure. We got to check on your high cholesterol. Okay, that thyroid number was off 6 months ago. We're probably going to recheck that today. And let's talk about your sexual health. Let's talk about this. And then all of a sudden you're like, oh, by the way, my shoulder hurts. And they're like, well,
Mm,
we had a 20-minute visit and we're 19 minutes in. Like they're not going to have time to do a thorough evaluation. So every primary care physician's level of comfort with dealing with that stuff is very different. But you're never wrong to come see me for that kind of stuff. I promise your primary care doc is not going to be offended that you kind of bypass them to come in and see a specialist for your shoulder pain or your knee pain or whatever.
yeah.
But that's kind of the general approach that I would take.
Well, I was going to say too, kind of to your point earlier with PAs, NPs, things like that. I've found that like primary care physicians are incredibly intelligent human beings and they know a lot. But to your point, like there's so many different things that they have to worry about and they have such a short time to do it. And so oftentimes the musculoskeletal issues kind of get pushed off to the side. And they just don't deal with that as much as someone like yourself. And so having an expert be able to look at your shoulder or your knee or your elbow, whatever it is, and be able to tell you exactly what is going on, it's very helpful.
Yeah, and I think two things there. One, like the musculoskeletal issue is not going to kill you, right? Like you got a bad heart, you got high
Yeah,
cholesterol, like that can
right.
lead to serious life-altering consequences. So
Absolutely.
that should appropriately be worried about first in the primary care office.
Absolutely.
And the other there is, we just have such nuance with therapy. I think a lot of physicians just, it's so hard to stay, like you said, up to date on all this information. Like they'll be like, we'll have a concussion patient and they'll be like, oh, you need to stay out of school for 2 weeks. And it's like, well, actually, we try to get them back into school as soon as possible.
Yeah.
Like, hey, you have your shoulder hurts. Like, or let's say you have knee pain in a 16-year-old, and they're like, well, you should probably rest it for 2 weeks. Like, they're in competitive soccer season. Like, them sitting out, and maybe they're the starting center midfielder. Like, that's a huge deal to them. And so if we can have kind of a little more specialized nuance to like, hey, well, actually, I think we're just going to need to pull back on this particular part of practice. I think we'll still be able to play this weekend. Like, yeah, you might have to get subbed out a little earlier, but we can work through that. Like cross country, it's track season now. Like, maybe you got a little bit of shin pain and they're going to tell you to rest for 3 weeks. And you're like, well, if I rest for 3 weeks, like, there goes my first meet. There goes any hope of me qualifying for conferences. There goes hope of me qualifying for state. And so getting, again, truly to the true answer, the culprit, the faster we can do that, the better educated and smarter we can be about coming up with an appropriate plan of care.
Yeah, absolutely. Well, Dr. Reynolds, if someone wants to learn more about you, if they want to make an appointment with you, how can they do so?
Multiple different ways. You can find our office number, 515-440-2676, and ask to see me. You can go to our website, Capital Orthopedics, and schedule an appointment online. I give quite a variety of community lectures. So if you're on Facebook and I'm giving a lecture at Mercy's Gym or whatever it may be, you can come find me in those types of things as well. But yeah, easiest way is to usually call or schedule an appointment online, or just walk into our clinic here in Ankeny in the district and come in and see me.
Awesome. This has been absolutely amazing. Thank you so much for coming on today.
Absolutely. Appreciate you having me.
Yeah, thank you.